Hi, this is Dr. Max Fung, University of California, Davis in Sacramento, California. Today's topic is spongiotic dermatitis, the first of a number of patterns of inflammatory skin disease. Feel free to take a look at the remainder of our year-long curriculum on our website. And as expected for all inflammatory skin diseases, every single category ends in itis. So we won't be discussing any neoplasms other than the few notable examples wherein neoplasms mimic inflammatory skin disease. So what is spongiosis? As someone who's been both a student and a teacher for essentially my entire life, I like to pay tribute to those who have taught me. And this includes Dr. Mark Goldine, professor of dermatology at University of California, San Francisco. Back in the pre-digital age, he was a talented artist and showed me and provided me with this diagram of the skin that I use in many of my teaching sessions. Dr. Goldine was also a talented musician and organized and participated in a string quartet that had its one and only performance during my residency graduation. And it turns out that's actually the last time that I've played the violin in a semi-public setting, and perhaps that correlates with the fact that I have not had the pleasure of seeing Dr. Goldine since that year. The simplest definition of spongiosis is intercellular edema. Specifically, intercellular edema of epithelial cells. And it's very common to define spongiosis as intercellular edema of the epidermis. But I use the word epithelial here with intent to recognize the fact that spongiosis can also affect the epithelium of adnexal structures, hair follicles, and sweat ducts. Now, of course, differential diagnoses could be short or quite long. And so for this session, I'm going to be focusing on this list of a half dozen, if you will, core entities in the spongiotic dermatitis differential. But we'll really be spending most of the time simply learning how to recognize spongiosis and the many ways that it presents on hematoxylin and eosin-stained sections. By the end of the lecture, I'll expand the differential diagnosis of spongiotic dermatitis to slightly more than double the number of entities that I showed in the previous slide. But I'd like to now examine a few quotes from leaders in dermatopathology spanning nearly half a century. So the late A. Bernard Ackerman in 1978 wrote, "It is sometimes impossible histologically to distinguish one type of acute spongiotic dermatitis from another. An accurate histologic diagnosis can only be spongiotic dermatitis, and a note of histologic differential diagnosis should be added." Halfway around the world, in Tokyo, Japan, nearly half a century later, Tanei and Hasegawa stated that routine hematoxylin and eosin staining and immunostaining do not show a significant difference in the tissue response of spongiotic dermatitis of atopic dermatitis versus other eczematous dermatitis conditions such as allergic contact dermatitis. And finally, from a dermatopathology textbook that may be much more familiar to students of dermatopathology, from McKee, attempting to distinguish the various clinical subtypes of spongiotic dermatitis based on histologic features alone is generally futile. So you might rightfully ask, well, what's the point? What's the point of going beyond spongiotic dermatitis NOS, not otherwise specified, which I'll be using frequently? But hopefully by the end of this session, you'll appreciate some of the nuances in this differential diagnosis, and certainly the perceived lack or slow progress over the past many decades hasn't stopped investigators from advancing knowledge in this field, and certainly hasn't prevented dermatopathologists from trying to do the best clinical pathologic correlation that they can for every single case. And it's certainly been my experience that submitting providers are universally appreciative of pathology reports, even if the top line just says spongiotic dermatitis, to have a concise comment that accurately maximizes the clinical pathologic correlation for any particular case. And conversely, pathology reports that kind of tend to show the same kind of boilerplate list with no particular thought about the order of likelihood, etc., tend to be not as helpful. Now, one of the things that I think is confusing both to pathologists and clinicians and patients is that there's somewhat of a bit of variation in the terminology used for spongiotic dermatitis. And so here's that core differential diagnosis list, but the terms eczema and dermatitis tend to be used fairly non-specifically. There may be more precise usage by individual providers, but kind of in the aggregate of the healthcare world, these terms are sometimes used to designate one of these entities, or they're just used interchangeably. And personally, in my experience, atopic dermatitis is the most likely to simply be designated eczema, but certainly there's plenty of literature showing that any one of these entities will be called eczema, or sometimes the term eczema is just used to describe the whole group of disorders non-specifically when a more specific diagnosis is not available. And so for practical purposes, one can essentially swap the terms eczema or dermatitis for any of these entities. So nummular dermatitis is the same as nummular eczema and so on. Note, however, that nobody really says, at least in my world, nobody says seborrheal eczema anymore. Everyone says sebderm. But note that the original description of sebderm in 1887 by Paul Una was, in fact, seborrheal eczema. And for those who push through to the end, we'll finish off with this expanded differential diagnosis. Nevertheless, from a practical perspective of daily reporting, most of the entities in this session are going to be reported with the top line of spongiotic dermatitis. And so this is what I mean when I refer to the kind of the boilerplate differential diagnosis. And so boilerplate has historical origins, so it actually refers to like metal printing plates from like the newspaper industry in the way pre-digital age. But nowadays, a boilerplate or boilerplate text, it's basically any kind of phrase or written text that can be used kind of standardized, kind of without significant changes from the kind of the standard boilerplate text. And so way before clinicians were using electronic medical records routinely, pathologists have been using kind of boilerplate text or canned text or macros in their lab reporting systems essentially ever since computers were used in the workplace. And so here's a screenshot of our lab reporting system and our boilerplate text for spongiotic dermatitis. I suspect it's similar to those of most or all other dermatopathology practices in the world, but you can see the diagnosis section over here on the right, and then a microscopic description. We have billing and diagnosis codes, and then you can see the abbreviation for the codes over on the left. So this is kind of how we start our reports and then modify from there. And closer inspection of the diagnosis and notes section of the boilerplate text shows that you have a line diagnosis of sponge derm, and so really the essence of the report is what is in the note. And we have a boilerplate list here, but then it should be customized for the details of the actual case. And I am certain that we are not the only dermatopathology practice in the country who has multiple spongiotic dermatitis codes. Here's one for chronic spongiotic dermatitis. Back to our definition of spongiosis, intercellular edema of epithelial cells, we can see that the desmosomes, the structures in between the keratinocytes, are easier to see when the intercellular space is widened by the edema fluid, and this is best seen in the mid portion of the epidermis, the spinous layer, or stratum spinosum, also known as the prickle cell layer. And although the enhanced visibility of the desmosome is a critical clue to the presence of spongiosis, the desmosome is actually trying to stay normal. It's trying to maintain its cell-cell attachment. And so what is affected in spongiosis is another junctional complex, a protein complex between adjacent keratinocytes called the adherens junction. The adherens junction has a cytoplasmic face that's linked to the actin cytoskeleton, and it encircles the cell as a band, the zonula adherens, or spots. And so you can kind of think of it as kind of like a seatbelt or shapewear for the cell. And so it has that function, also a cell-cell adhesion function, but the cell-cell adhesion is not as strong. And so with spongiosis, there is evidence for a T-cell mediated process interferon gamma producing T cells, resulting in cleavage of one of the critical proteins in the adherence junction known as E-cadherin. And with the immunologically mediated cleavage of E-cadherin, there's sufficient loss of the cell-cell adhesion to allow spongiosis to occur. And only in the most severe examples of spongiosis do we get secondary destruction of the desmosomes, resulting in spongiotic vesicles. And for any cluster of differentiation geeks out there, E-cadherin is CD324. And going back to our diagram, we now see spongiosis of the epidermis, intercellular edema, reflecting compromise of the adherens junction, but the desmosomes are still intact. And with sufficient intercellular edema, loss of the desmosomes as well, resulting in spongiotic vesiculation or spongiotic vesicle formation. And peripheral to a spongiotic vesicle is invariably spongiosis with intact desmosomes. And note that a variety of cells are present within spongiotic vesicles, which we'll take a look at in detail. Spongiotic dermatitis is also frequently stratified by acuity, so histopathologic features correlate with acute, subacute, and chronic lesions. Acute spongiotic dermatitis is characterized by a normal or unaffected stratum corneum, and this is a pattern of basket weave orthokeratosis on the trunk and proximal extremity and face. Acute spongiotic dermatitis, especially those cases rising to the level of needing a biopsy, tend to have fairly prominent spongiosis, so spongiotic vesicles are common. Spongiotic vesicles typically contain any combination of a variety of inflammatory cells, but the most common are Langerhans cells. And so when Langerhans cells seem to predominate or exclusively occupy a spongiotic vesicle, we can call these Langerhans cell collections. And when spongiotic vesiculation is florid enough, the vesicles are large enough to be appreciated clinically. And a classic example could include an acute vesicular patch test reaction or an acute poison oak dermatitis. Subacute spongiotic dermatitis is largely identified by the presence of parakeratosis rather than orthokeratosis. And finally, chronic spongiotic dermatitis is characterized by a thickened or acanthotic epidermis. In this context, the terms acanthosis and hyperplasia tend to be interchangeable, sometimes with the modifier psoriasiform, and we'll take a detailed look at these terms and the prototypical diseases associated with them in the session on psoriasiform dermatitis. And chronic spongiotic dermatitis is indeed part of that psoriasiform dermatitis group. We'll take a look at that here, and we can see that with chronic spongiotic dermatitis, the acanthosis or epidermal hyperplasia tends to be described as irregular, in contrast to the regular psoriasiform hyperplasia of psoriasis. So with psoriasis, the elongation of the reedy ridges tends to be fairly equal in length, and with chronic spongiotic dermatitis, the reedy ridge length tends to vary, or they tend to be uneven or irregular. So the phrase irregular acanthosis or irregular hyperplasia, with or without the modifier psoriasiform, is typically used to describe the appearance of chronic spongiotic dermatitis. Hypergranulosis, or a thickened granular layer, also typifies chronic spongiotic dermatitis, with the caveat that one must reference that against the anatomic site. So remember that acral skin, the palm and sole, normally has a more prominent granular layer, so the assessment needs to be relative to that baseline. And with chronicity, the degree of spongiosis may subside and be minimal or even inapparent. There's just a little bit here. Now, can you see it? And now, still? Clinically, chronic spongiotic dermatitis is characterized by lichenification, or a lichen-like appearance to the skin, and the histopathologic correlates of lichenification include compact orthokeratosis, resembling the stratum corneum on acral skin, and fibrosis of the papillary dermis. And here we see overlap and essentially the same features of lichen simplex chronicus. And so a patient like this one with chronic atopic dermatitis will have predominant lichenification, and one could ask, is this a chronic dermatitis or is it lichen simplex chronicus? Essentially, they can be viewed as either on a spectrum or one and the same. And it turns out that the spectrum of spongiotic dermatitis from acute to subacute to chronic to lichen simplex chronicus is very much a spectrum in clinical practice. So for example, in this partial sampling, we can see features of acute spongiotic dermatitis with crust and spongiosis juxtaposed directly with features of chronic spongiotic dermatitis, namely compact orthokeratosis with hypergranulosis. Moreover, the dynamic process of spongiotic dermatitis tends to wax and wane. So the dermatitis can be intermittent. Sometimes it resolves, sometimes it's flaring. And so one of the clues that we can see on biopsy sections is the alternating parakeratosis and orthokeratosis. Specifically, parakeratosis overlying orthokeratosis reflects an intermittent or late resolving stage of the dermatitis process. Let's take a look now at the different cells that can be present in areas of spongiosis, starting with the Langerhans cells. Langerhans cells are a type of macrophage or histiocyte and readily identified on H&E, being larger than small lymphocytes and having a characteristic reniform nucleus with abundant pale cytoplasm. There are a variety of synonyms for the Langerhans cell collection, including the LC microgranuloma and LC microvesicle, and these newer terms, such as the inflammatory dendritic epidermal cell, also known as type 2 Langerhans cell, reflect advanced understanding in the pathogenesis of spongiotic dermatitis. Specifically, the collections of Langerhans cells are not thought to be the resident Langerhans cells of the skin, but rather similar cells that are recruited in during active dermatitis. But we can't really distinguish these different subtypes of Langerhans cells on H&E or even readily by immunohistochemistry, so we collectively just refer to all of these cells in the spongiotic vesicles as Langerhans cells with their reniform nuclei and distinctive pale cytoplasm, even though we recognize that it's actually a mixed population of cells. Langerhans cell histiocytosis provides ample opportunity to see numerous Langerhans cells and may be regarded as the neoplastic counterpart of the cells that comprise the Langerhans cell collections. And if you've seen enough examples, finding them can start to seem pretty easy. And note that even amidst the neoplastic Langerhans cells in Langerhans cell histiocytosis is a scattered population of other inflammatory cells, small lymphocytes, eosinophils, and neutrophils. Other than the Langerhans cells, lymphocytes are most commonly found in areas of spongiosis, typically small lymphocytes with small, more or less round nuclei and scant or inapparent cytoplasm, readily seen even without the yellow circles. And it's commonplace to see spongiotic vesicles containing admixed lymphocytes and Langerhans cells. Here are some lymphocytes surrounding a Langerhans cell. Even without a clear spongiotic vesicle, both cells are typically present. Scattered small lymphocytes. So here's a little test. Is this a spongiotic vesicle? Within the dashed circle? No, this is a dermal papilla. See the little cluster of red blood cells? And remember the normal reedy ridge pattern of the dermal-epidermal junction and the fact that tissue sections inevitably get sectioned somewhat tangentially. And for mini quiz number 2, is this a Langerhans cell? Perhaps with a closer look? Again, no. This is a keratinocyte. Surrounded by widespread, cleaved, dysfunctional E. cadherin, but with the desmosomes holding on tight around the upper portion of the cell. And notice the lack of a classic areniform nuclear contour. The fact that lymphocytes are normally present in areas of spongiosis in fact represents a crux of one of the most challenging differential diagnoses in all of dermpath, that of spongiotic dermatitis versus early mycosis fungoides. And the pattern of the lymphocytes in spongiotic derm can be characterized using the purely descriptive term of exocytosis, that of lymphocytes migrating from the dermis, where they normally reside, into the epidermis. And we see a fairly scattered distribution of small non-atypical lymphocytes localized to areas of spongiosis. Whereas in contrast, the neoplastic lymphocytes in mycosis fungoides are often described as being epidermotropic, or skin-homing T cells that are neoplastic, and histologically it's characterized by increased numbers of lymphocytes, often with exaggerated clearing or retraction or haloing around them. And cytologic atypia is expected with convoluted nuclear contours, but of course in practice that can be quite subjective. And even with a classic Potrier collection or Potrier microabscess with atypical lymphocytes forming a collection within the epidermis, you can see that there still is some surrounding spongiosis. Compare that with the classic spongiotic vesicle on the left. We have admixed lymphocytes and Langerhans cells and relatively greater spongiosis. But in practice, the assessment is quite subjective in many cases, trying to determine if the number of intraepidermal lymphocytes is greater than that which is typically seen in spongiotic dermatitis, or for the number of lymphocytes in the epidermis, is there disproportionately little spongiosis than would be expected in a typical spongiotic dermatitis. Can be quite subjective. The presence of eosinophils within a spongiotic epidermis defines eosinophilic spongiosis. And with the idea that there is a certain minimum amount of spongiosis required for the eye to appreciate, I would regard for practical purposes the presence of any eosinophil within epithelium to constitute eosinophilic spongiosis. So again, for practical purposes, eosinophilic spongiosis equals eosinophils in the epithelium. And there is a popular happy mnemonic for remembering entities that are typically associated with eosinophilic spongiosis, classically including immunobullous disorders such as bullous pemphigoid, wherein even in the absence of a subepidermal blister, one can see eosinophils lining up along and around the dermal epidermal basement membrane zone in conjunction with junctional vacuoles as a clue to bullous pemphigoid. I suspect that probably any form of spongiotic dermatitis could conceivably contain an intraepidermal eosinophil or two, but when one sees eosinophilic spongiosis, one typically thinks of allergic contact or photoallergic drug reactions, as well as pregnancy-associated hypersensitivity and the almost never biopsied erythema toxicum of newborns. Eosinophils are so characteristic within the host response of arthropod bite reactions and similarly scabies that one would question the diagnosis if eosinophils are not present, and eosinophilic spongiosis is also frequently encountered. The vesicular stage of incontinentia pigmenti is characterized by a near pathognomonic combination of intraepidermal eosinophils and dyskeratosis. And of course, one can also consider some of the so-called eosinophilic dermatoses, such as eosinophilic folliculitis and various drug reactions, including DRESS. Although I'll highlight with DRESS that even though the E stands for eosinophilia, it's referring to peripheral eosinophilia, so one does not necessarily need to see lesional skin eosinophils, much less eosinophilic spongiosis, to make the diagnosis of DRESS. Neutrophils within a spongiotic epithelium defines neutrophilic spongiosis. And as per eosinophilic spongiosis, for practical purposes, I would regard the presence of even a single neutrophil within an epithelium, with or without overt spongiosis, to constitute neutrophilic spongiosis. Overall, I would regard neutrophilic spongiosis as a little bit more commonly encountered and overall less specific than eosinophilic spongiosis. As you can see, the differential diagnosis is a bit longer, and part of this may be attributed to the fact that external trauma and wound healing normally invokes a neutrophilic reaction in the acute phase. But even considering that, there are a variety of disorders that may show neutrophilic spongiosis. So here is a clinical testing opportunity that should not be too much of a challenge for the dermatologists and the astute dermatopathologists. The hope being that you will be able to look your attending or colleague straight in the eye and say, with confidence, toxicodendron. Which brings us now to the prototype of acute spongiotic dermatitis, allergic contact dermatitis, frequently mediated by the toxicodendron genus of flowering plants causing poison oak and poison ivy. And shown here in the upper left is the common nickel allergy as well. And so with these very distinctive clinical presentations of allergic contact dermatitis, it's not surprising that it's not usually biopsied. And add to that the fact that biopsies of allergic contact dermatitis show spongiotic dermatitis NOS, not otherwise specified. So we'll take a look at some characteristic features, but in the end, there's no specific feature that is going to confirm or exclude the diagnosis of allergic contact dermatitis in the vast majority of cases. But I said before that that fact has not stopped many among us. So in fact, allergic contact dermatitis has been the subject of some recent research by dermatopathologists. And Dr. Rosa and Steve Billings and colleagues from the Cleveland Clinic showed that Langerhans cell collections rather than eosinophils are a clue to the diagnosis of allergic contact dermatitis. So that intraepidermal Langerhans cell collection is associated with this diagnosis. And although the prevalence of Langerhans cell collections in allergic contact dermatitis does not seem to be high enough to absolutely rely on, it's still a relatively specific finding, and one that my colleagues and I have also observed at UC Davis. And associated with that result was the finding that eosinophils were not associated with allergic contact dermatitis. So that is also interesting because there is somewhat of a dogma that is now debatable that eosinophils are characteristic of allergic contact dermatitis, both dermal eosinophils as well as eosinophilic spongiosis, a la the happy mnemonic. But that is now coming under question. And as one anecdote from our practice, here's an example of an acute spongiotic dermatitis. And we can see that it is rich in eosinophils in the dermis, and there's also eosinophilic spongiosis. But this, in fact, was clinically proven to not be allergic contact dermatitis. Our group's initial findings were reported by Dr. Jeff Wu at the 2022 College of American Pathologists meeting, and it seemed that in the cases with the very highest eosinophil density, there was actually an inverse correlation with a diagnosis of clinically and patch test confirmed allergic contact dermatitis. And so to recap this case, if one encounters a biopsy like this as a pathologist, one has no choice but to make a diagnosis of spongiotic dermatitis with eosinophilic spongiosis, and one would appropriately list one or more of the entities on the happy mnemonic for eosinophilic spongiosis. But in fact, in this case, it's very likely that the correct diagnosis is none of those entities. And so we hope there will be more to follow on the diagnostic specificity of various histopathologic attributes in allergic contact dermatitis and other forms of spongiotic dermatitis. So for now, as has been recognized by experts in the field for decades, and now more if you will, rigorously confirmed using quantitative methods and robust clinical correlation, the Langerhans cell collection appears to be the single most distinctive histopathologic feature in allergic contact dermatitis. And so if allergic contact dermatitis is generally distinctive enough that it doesn't need to be biopsied, but with rare exception, even more so is the case with irritant contact dermatitis, where exposure to the irritant is stereotypical and dose-dependent and not dependent on prior host sensitization. So needless to say, irritant contact dermatitis is not usually biopsied, and when it is biopsied, it will typically show a picture of spongiotic dermatitis, NOS. But of course, that's not going to stop us dermatopathologists from finding features that can at least suggest the diagnosis. So those would include things that are attributable to the external trauma and the associated acute inflammatory reaction, neutrophilic spongiosis, even in mild cases, and in severe cases, intracellular edema with ballooning degeneration of keratinocytes, and in extreme cases, superficial confluent necrosis and ulceration. Histopathologic attributes said to favor irritant contact dermatitis over allergic contact include the swelling and bursting of the epidermal keratinocytes, ballooning, and reticular degeneration, usually accompanied by necrosis and neutrophils, and sometimes acantholysis, which is a discohesion of the keratinocytes associated with loss of desmosomes. And looking at it from the other perspective, features that favor allergic contact dermatitis over an irritant contact dermatitis would be the Langerhans cell collections, as we've discussed, and also eosinophils, and also, interestingly, the presence of follicular spongiosis. So here's one more view of a neutrophilic spongiotic dermatitis, for which the differential diagnosis should include irritant contact dermatitis. In more severe examples of irritant contact dermatitis, there may be superficial necrosis, typically confluent over the superficial or outermost epidermis, characterized by eosinophilia of the cytoplasm and variable loss of the nuclear basophilia. Atopic dermatitis, also known as eczema or atopic eczema, may be the most common form of spongiotic dermatitis, but that really does not correlate at all with what is most commonly biopsied. Again, the clinical presentation is quite characteristic, and in the chronic phase, this would be the prototype of a chronic eczematous dermatitis leading to lichen simplex chronicus. There's also a distinctive papular or follicular variant, which we'll come back to in a little bit. And so again, atopic dermatitis, not usually biopsied, but atopic dermatitis is a chronic and waxing and waning disease. And so, as is typical for dermatopathology practices, there is a selection bias towards biopsy of chronic, atypical, or refractory cases. And so biopsies of atopic dermatitis typically show a profile of spongiotic dermatitis, NOS. And perhaps analogous to the situation with allergic contact dermatitis, there is somewhat of a dogma, also debatable out there, that dermal eosinophils are typical or specific for atopic dermatitis, but that also has not really been kind of vigorously demonstrated, in my opinion. It has been appropriately pointed out that eosinophils may be degranulated in lesional tissue, and that can make them more difficult to identify and quantify. But in a detailed study of atopic dermatitis by all accounts, a great dermatopathologist, the late Dr. Martin C. Mim Jr. and colleagues, in their study of atopic dermatitis with controls, they looked specifically for eosinophils and found them in less than half the cases. This photo on the left was from the last time that I saw Dr. Mim in person, here with my friend and former co-resident, Dr. George Murakawa. But the concept of the degranulated eosinophils remains quite compelling in my opinion. And so although Dr. Mim and coworkers found eosinophils in less than half the cases, other atopic dermatitis experts, such as Dr. Kiel and coworkers from Germany, also Dr. Kristen Lieferman from the University of Utah, have demonstrated the presence of degranulated eosinophils. And in this one study, if one looked using more sensitive methods, such as immunohistochemistry for eosinophilic granule protein, EGP, eosinophils could be found in 96% of atopic dermatitis biopsies. And if you're thinking that this little bit of knowledge is somewhat arcane, well, you'd be right. It happens to be a little pocket of knowledge and interest that I have. And if you're interested in learning more, I will proudly refer you to this article cited below on the role of eosinophils in the differential diagnosis of inflammatory skin diseases, written with my colleague, Dr. Leah Caro Chang. And here is a biopsy that would be compatible, but not by histology alone specific for atopic dermatitis. I'll simply point out that although it's a fairly nonspecific spongiotic dermatitis, there's one eosinophil for what it's worth, basically nothing. But more characteristic of atopic dermatitis is that there is a subacute to chronic profile. So we do have parakeratosis and we do have a prominent granular layer, and this would be typical for a biopsy of atopic dermatitis. Here's another biopsy that shows something similar but different. So what would you say if I told you that this patient also had atopic dermatitis? What's going on here? It may be a bit more obvious at slightly lower magnification. So the finding of spongiosis within follicular epithelium evokes a relatively short list of considerations, including papular or follicular atopic dermatitis. Papular eczema tends to most closely resemble lichen nitidus, which is not a spongiotic disorder. That falls under the lichenoid and or granulomatous classifications. Numerous tiny pinpoint papules. Correlating histologically to spongiosis localized to hair follicles, specifically the upper portion of hair follicles known as the infundibulum, so infundibular follicular spongiosis, and the term infundibulofolliculitis is sometimes used. Being focal structures, hair follicles are difficult to capture on any given tissue section, so what one often sees is kind of an edge section of a follicular infundibulum. We almost never get perfect sections through most or entire hair follicles. Sometimes it's just what appears to be kind of a funny shaped reedy ridge that in actuality is an edge section of a follicular infundibulum. And interpretation is facilitated by sometimes taking a step back and taking a composite assessment of multiple tissue sections to get a sense for whether the spongiosis is localized to hair follicles or not. In terms of differential diagnosis, another rare entity that I'm told is essentially clinically and histologically the same as papular eczema but occurs in non-atopic individuals is known as recurrent and disseminate infundibulofolliculitis. It's also histologically relevant that the epithelium of the sweat ducts can look similar, if not indistinguishable, from a follicular infundibulum in a given tissue section. And so the differential also includes the various forms of miliaria. So ecrine miliaria involving the ecrine glands, and then also apocrine miliaria, also known as Fox-Fordyce disease, in which spongiosis is localized to the upper portion of the apocrine sweat duct, can show a similar, if not indistinguishable, appearance of adnexal epithelial spongiosis. Nummular dermatitis goes by a variety of names, including nummular eczema, nummular neurodermatitis, discoid dermatitis, but again, very distinctive clinically and thus not very commonly biopsied. As with most instances, there's a selection bias for biopsying chronic, refractory, or atypical cases. The histopathology of nummular dermatitis is that of spongiotic dermatitis NOS, but I put some comments here. So nummular dermatitis may show some eosinophils, occasional neutrophils, and uncommonly a lichenoid pattern. And I put these adjectives in quotes because it turns out that multiple authors, mutually exclusive from different textbooks, have used these exact words to describe the status of these cells and patterns in nummular dermatitis. as a annoying and disfiguring and disabling but non-deadly disease, one might not expect to see a lot of funded research on nummular dermatitis, and that actually is, for the most part, true. But that's still not going to stop the experts with the most passion, expertise, and inquisitiveness from looking at the pathogenesis of nummular dermatitis. And so one example of that would be the research group of Dr. Gil Josipovic. In this study here, they looked at nerve fiber density in lesional nummular dermatitis, and interestingly, they found reduced nerve fiber density, which contrasts with the increased number of immunoreactive nerve fibers seen in atopic dermatitis. This might seem to contrast with recent data in which a number of cases of nummular dermatitis were subjected to bulk RNA sequencing and compared with controls as well as atopic dermatitis and psoriasis lesions. And it turned out that the molecular signature of nummular dermatitis was more aligned with that of atopic dermatitis. And this was supported by the fact that there is evidence of clinical efficacy for dupilumab in patients with nummular dermatitis. Dyshidrotic dermatitis, also known as dyshidrotic eczema, has a couple of older historical names, pompholyx, so chiropomphylix involving the hands, and podopomphylix when it involves the feet, reflecting the fact that this disorder is essentially limited to the acral or palmoplantar locations. Anecdotally, I've seen rare cases that extended proximally up the distal extremities, but only when acral involvement was quite extensive and severe. And so knowing that the stratum corneum of acral skin is thick and compact, when those spongiotic vesicles form, it's a lot harder for them to break or to get excoriated. And so they tend to stay intact, resulting in a very clinically distinctive appearance of little tapioca pearl type vesicles on the hands and feet, often collecting on the lateral edges of the digits. Now, who would want to biopsy the finger? So this is, again, very rarely biopsied, but we do tend to see spongiotic vesicles intact on dyshidrotic dermatitis for the reason I mentioned. And for what it's worth, anecdotally, I feel like I never see eosinophils in dyshidrotic dermatitis. I'm not aware of any quantitative studies that demonstrate this, but I typically see no eosinophils in cases that seem to be clinically confirmed dyshidrosis. And Dr. Beverly Faulkner Jones and colleagues writing in Lever's Dermatopathology also commented that eosinophils tend to be few or absent in this entity. So here is a precious punch biopsy of acral skin with spongiosis and spongiotic vesicles. And with that thick, compact stratum corneum, it's easy to see that that spongiotic vesicle is going to stay intact for a while. But, truth be told, I suspect that intact spongiotic vesicles is more a function of the anatomic site rather than a function of dyshidrosis per se, beyond the fact that dyshidrosis is essentially limited to involvement on acral skin. With the id reaction, we get Freudian dermatopathology, and this is characterized by acute, localized, or generalized eczematous reactions, usually associated with a known trigger, classically superficial fungal infection like tinea pedis. And on pathology, it's spongiotic dermatitis, not otherwise specified. Yet again, we dermatopathologists are smart, observant, and caring individuals, so we try. And so it has been said that in id reactions, eosinophils may be present. Papillary dermal edema is often present. And the T cells in the epidermis are said to be mostly CD8 positive, whereas those in the dermis mostly express CD4. Moving on to seborrheic dermatitis, extremely common and only rarely biopsied, and only tending to be biopsied in unusual or refractory cases, usually subacute or chronic in duration. In the context of spongiotic dermatitis, seborrheic dermatitis typically shows shoulder parakeratosis with associated neutrophilic crust and often follicular spongiosis. inflammation tends to be chronic, so dermal plasma cells are often seen. The presence of colonizing yeast spores correlates with the known pathogenesis of seborrheic dermatitis. And seborrheic dermatitis, particularly on the scalp, can be difficult, if not impossible, to distinguish from psoriasis, hence the clinical entity sebopsoriasis and corresponding overlap in histopathologic features in these cases. For example, dilated papillary dermal vessels, a hallmark of psoriasis, has also been reported in sebopsoriasis. The shoulder parakeratosis of sebderm refers to that junction of epidermis and follicular infundibulum, shown here with associated parakeratosis and underlying follicular spongiosis in a vellus hair follicle, and here in a terminal hair follicle. And so again, the shoulder is the epicenter of the action in seborrheic dermatitis, that angle of the epidermis joining the follicular infundibulum. And although the phrase shoulder parakeratosis is used, one doesn't necessarily always see parakeratosis. So for example, this is a good example of follicular spongiosis. I do not really see the parakeratosis. I see compact orthokeratosis, probably with some nuclei there, but I see more prominently spongiosis at that shoulder. And so it starts with the spongiosis, and then you can get parakeratosis, and then typically neutrophilic crust over that. So basically the shoulder is the epicenter, but one doesn't necessarily have to see parakeratosis. And if one were to scrutinize the cornified layer, the stratum corneum, or the cornified portion of the follicular infundibulum, yeast spores, presumably various species of Malassezia, are typically seen, corresponding with the typical head and neck distribution of Malassezia colonization and seborrheic dermatitis. And another example, again typically from hair-bearing area of the scalp, now with more extensive neutrophilic crust extending well beyond the shoulder. And we can see the spongiosis is accentuated at that angle of the epidermis and hair follicle, and even the overlying crust, although diffuse, seems somewhat more prominent and thick at the shoulder. The spongiosis is typically associated with at least some lymphocyte exocytosis. And so that rounds out the initial differential diagnosis for spongiotic dermatitis, all disorders commonly encountered clinically but only infrequently biopsied. Stasis dermatitis is a form of eczematous dermatitis associated and attributed to underlying venous stasis. So this is largely limited to below the knee in adults with venous stasis. And so the key to being able to include stasis dermatitis in your differential diagnosis is the recognition of venous stasis changes. So in addition to the somewhat restrictive clinical setting, histologic features of venous stasis include a combination of findings that taken together are distinctive: extravasated red blood cells, subsequent deposition of hemosiderin and siderophages, and most characteristically the vascular changes and vascular pattern in venous stasis, which is characterized by clusters of small, slightly thick-walled vessels. The term nodular angioplasia has been used by some. Again, clusters of small blood vessels whose vessel wall caliber is just slightly thicker than you would expect for the overall size of the vessel, in concert with extravasated erythrocytes and hemosiderin. And once the presence of venous stasis has been confirmed, a perennial challenge in clinical pathologic correlation is the determination of whether the biopsy findings represent pure stasis dermatitis or any of the other forms of spongiotic dermatitis present on skin with background venous stasis. And in addition, there's a spongiotic variant of pigmented purpuric dermatosis. Although most drug reactions are not biopsied, in my experience, drug reactions are frequently biopsied, especially in hospital inpatients. I always tell my colleagues and trainees that drug reactions can do anything. So drug reactions can mimic any of the standard patterns of inflammatory skin diseases. But having said that, probably either spongiotic dermatitis or interface dermatitis are most commonly encountered. And most distinctively, the combination of patterns, so a spongiotic and interface pattern or any kind of combined pattern that doesn't really fit other known inflammatory skin diseases, generally is a clue to the possibility of a drug reaction. And here we also have an opportunity to perhaps debunk the dogma about eosinophils in drug reactions. And so while we continue to look for eosinophils to support a drug reaction, and we sometimes question a diagnosis if we can't find them, in fact, it's well documented that you do not need to have eosinophils in a drug reaction. So while it's nice to see them, they are not required. What is required is clinical confirmation. Perhaps similarly, it's said that deep dermal involvement of the inflammatory infiltrate supports a drug reaction, but again, not required. Although I found this last little tidbit to be interesting, we see, and there is some evidence to support that the inflammation in drug reactions might have a predilection for the eccrine unit. And this reminds me of one of the many wise teachings of my former attending, Dr. Timothy Berger at UCSF. This would not be based on inductive reasoning or deductive reasoning, but perhaps seductive reasoning. But in this case, there actually is some evidence to support the assertion as cited below. And so in this anecdotal example of a clinically confirmed trimethoprim sulfomethoxazole Septra-Bactrim induced drug reaction, we see spongiotic dermatitis. There happens to be a lot of extravasated erythrocytes, so perhaps this is a purpuric drug reaction. There's not a whole lot of eosinophils, but they are there, rest assured. But more interesting to me is the presence of a little bit of a combined pattern with interface changes with some necrotic keratinocytes. And look, it's actually centered around an acrosyringium, the intraepidermal portion of an eccrine sweat duct. And here in a single slightly higher magnification view, we can see an apparent lonely eosinophil amidst a sea of red blood cells, perhaps attracted to that epicenter of inflammation around the sweat duct, with the overlying confluent dyskeratosis centered upon the acrosyringium. Photoallergic dermatitis also occasionally biopsied, and of course clinical correlation can be quite important for this entity. On pathology, we cannot really expect anything more than spongiotic dermatitis NOS. But of course, we can search for relatively subtle clues that can help us order our boilerplate differential diagnosis of spongiotic dermatitis. And so for photoallergic dermatitis, it said that lymphocyte exocytosis tends to be more prominent, and also similar to drug reactions, the presence of deep dermal extension of the perivascular or periadnexal inflammatory infiltrate with eosinophils does tend to support a photoallergic dermatitis, specifically a systemic drug reaction, with specific examples listed here. In this one example of a photoallergic dermatitis, it's pretty much chronic spongiotic dermatitis NOS, so a little bit of epidermal hyperplasia, minimal epidermal spongiosis, and a mostly superficial dermal inflammatory infiltrate. At higher magnification, we can better appreciate that epidermal hyperplasia with hypergranulosis and relatively mild spongiosis. Another feature shown here that's not classically a feature of photoallergic dermatitis is the presence of one or a few necrotic keratinocytes, one circled here at the junction, and at least one more superficially as well. So I'm not exactly sure what that means, but I know that sometimes just in normal skin you can see an occasional dead red. But in addition, perhaps there's a little bit of an overlapping element of phototoxicity here. So you can get the superficial necrosis, so-called sunburn cells. And also lichenoid variants of photoallergic dermatitis have also been described. So one might consider a little bit of a lichenoid element being present, even though we don't actually see an overt lichenoid or band-like infiltrate in this particular case. But more distinctive in this case is the presence of deep dermal eosinophils, albeit sparse. Urticarial dermatitis is not an entity that I think you would typically find on most differential diagnosis lists for spongiotic dermatitis, but it is an entity that has been increasingly recognized in the literature, and so I felt prompted to include it here. Urticarial dermatitis may be regarded as a subset of another relatively obscure entity, the dermal hypersensitivity reaction pattern, or DHR. And by definition, urticarial dermatitis exhibits an urticarial appearance clinically and is idiopathic regarding etiology. Anecdotally, the term had been in use by at least some practicing clinicians for many years prior to its introduction into the literature by Dr. Stephen Cosard and colleagues in 2006. Patients present with urticarial papules and/or plaques. With another large series released by the Mayo Clinic, Dr. Lawrence Gibson and colleagues, showing that in many cases with careful clinical pathologic correlation, some of these patients can be more specifically classified as atopic, nummular, or contact dermatitis. For those interested in a deeper dive into urticarial dermatitis and DHR, I'll refer you to my prior YouTube lecture, as well as the pathologyoutlines.com section that I wrote with Dr. Jeff Wu. There's also a section on urticarial dermatitis in uptodate.com by Dr. Matthew Zerwas. But for the purposes of the differential diagnosis of spongiotic dermatitis, urticarial dermatitis and the DHR reaction pattern in general is defined as a superficial and mid-dermal perivascular lymphocytic infiltrate with eosinophils and typically minimal to absent spongiosis. So in contrast to classic spongiotic dermatitis, spongiosis is minimal or even absent. Sometimes deeper sections are needed to identify even minimal spongiosis. And compared to most spongiotic dermatitis, which is traditionally classified as having a superficial dermal perivascular infiltrate, in the DHR reaction, the inflammation tends to extend a little bit deeper, so-called mid-perivascular. And here's one example of urticarial dermatitis. Again, this is merely the dermal hypersensitivity reaction pattern. One would need to confirm the urticarial nature of the disorder clinically and also exclude other more specific diagnoses to arrive at a diagnosis of urticarial dermatitis. But the typical pathology is minimal to absent epidermal changes, so I see perhaps maybe some scant spongiosis here, but I really would need to go to higher magnification to confirm that. And I see superficial and mid-perivascular, mostly lymphocytes, but by definition at least one eosinophil. And unlike urticaria itself, urticarial dermatitis is prone to excoriation, and this may be attributable to the minimal spongiosis that is occurring, allowing the epidermal barrier to be disrupted secondary to pruritus. So here we can see focal superficial confluent epidermal necrosis, and the clinical correlate is the focal hemorrhagic crusts observed clinically. As a practical note, I have a low threshold for getting deeper sections when I encounter one of these biopsies. Sometimes deeper sections will reveal quite prominent spongiosis, or sometimes even a different diagnosis like folliculitis, or once I even saw scabies. And along the lines of pathogens, dermatophytosis and other superficial fungal infections are typically associated with a spongiotic dermatitis. So the use of fungal stains is routine in this area. Typically, it's a spongiotic dermatitis with eosinophils, and it's important to remember to look at the hair follicles. Sometimes the stratum corneum will be negative, but the organisms will be present, sometimes plentiful, but only within the follicular canals, so-called Maiocchi granuloma. Pityriasis rosea is a unique and distinctive eruption. Although traditionally classified in the dermpath textbooks as a spongiotic dermatitis, clinically it's not eczematous. It's typically classified as a papulosquamous eruption with a distinctive initial herald patch followed by a generalized eruption, mostly on the torso, generally following relaxed skin tension lines in a pattern resembling a tree. And although clinical correlation is still nearly always required, there are a few histopathologic features considered to be distinctive for PR, including caps of parakeratosis, lymphocyte exocytosis, extravasated red blood cells, and occasionally rare necrotic keratinocytes. And while any one of these findings is probably not very specific, seeing two or more of them in combination tends to increase one's diagnostic confidence. So these caps of parakeratosis have also been described as mounds or resembling a lenticular cloud. In all cases, the parakeratosis being focal, not diffuse or confluent, and shown here in concert with underlying extravasated erythrocytes. And shown here a more multifocal pattern of parakeratosis with underlying spongiosis and arguably somewhat prominent exocytosis of lymphocytes. And sometimes there's even enough exocytosis to make you start having some of those MF thoughts. Don't ignore them. They are there. Doctors certainly do love our signs, and so this is one that I learned about just this year. The teapot sign in Pityriasis rosea is a more specific description of that cap or mound of parakeratosis. So as you can see here, the focal parakeratosis is kind of lifting off on one side, but it's attached on the other side. And so that has been said to resemble a teapot. And it's actually been it has been debated about whether that refers to the spout of the teapot or the lid of the teapot as shown here. The one on the bottom left is the one that was in my office at the moment I learned about the teapot sign. And some observers have even leveraged the ambiguity of the teapot sign and have proposed the salute sign as a less ambiguous clue to describe the same histopathologic feature. And the final entity for this lecture is Blaschkitis, also known as Blaschko dermatitis, a relatively recently recognized category of acquired skin diseases with a distinctive distribution, linear lesions that follow the lines of Blaschko. These are essentially the lines created when you follow the pattern of skin cell migration during embryogenesis. And the best known example, of course, would be lichen striatus. That shows different histology, lichenoid or lichenoid in granulomatous. With the Blaschkitis subset of Blaze, the histologic pattern is Spongiotic dermatitis. In this one example of clinically confirmed Blaschkitis, one sees epidermal hyperplasia with somewhat irregular elongation of reedy ridges, or irregular epidermal hyperplasia, or irregular psoriasiform hyperplasia, whatever term you like to use. There is also parakeratosis with crust. In the context of admixed acute, subacute, and chronic changes. So off to the right side of the biopsy, we have compact orthokeratosis with hypergranulosis, consistent with chronic spongiotic dermatitis or a component of lichen simplex chronicus. We have subacute parakeratosis and then foci of evident spongiosis. The spongiosis is invariably accompanied by varying degrees of lymphocyte exocytosis, and there's also a seeming random necrotic keratinocyte here. Serum crust in the stratum corneum is a commonly encountered finding in spongiotic dermatitis in general, but is not specific for any one form of spongiotic dermatitis. And at higher magnification, we can confirm the expected findings. We have spongiosis, we have exocytosis of lymphocytes, perhaps an entrapped Langerhans cell, and a background of subacute and chronic changes with hypergranulosis and compact orthokeratosis. More spongiosis, perhaps with a rare Langerhans cell. And other areas showing just chronic spongiotic dermatitis with compact orthokeratosis, hypergranulosis, and minimal spongiosis. So what is the point of showing you these few more repetitive images of spongiotic dermatitis in its acute, subacute, and chronic forms? Well, the point is that there's nothing specific here microscopically. The way you make the diagnosis is by correlating with that very distinctive linear Blaschkoid pattern. Which brings us back full circle to the fact that attempting to distinguish the various subtypes of spongiotic dermatitis based on histology alone is generally futile. And while it seems we've always had and probably will continue to have the security blanket of the spongiotic dermatitis boilerplate, just relying on that boilerplate alone is not going to make you the best dermatopathologist or the best physician for your patient. Rather, the boilerplate should merely be the starting point for what in the end would be a very customized patient-specific report, with the pathologist clinging to any histopathologic clues that they can identify, however weak, and the clinician providing as much clinical information that will facilitate the correct and optimal clinical pathologic correlation. And so with that, this introductory session on spongiotic dermatitis comes to an end, but one might appreciate that that is merely the juncture where clinical pathologic correlation begins, a defining attribute of a physician and particularly for pathologists and dermatopathologists. And as exemplified by sessions occurring at the World Congress of Dermatology with expert dermatologists and dermatopathologists continuing to gain experience through continued and repeated detailed clinical pathologic correlations, and ways to maximize effective communication between clinicians and dermatopathologists.